Good afternoon, good evening. My name is Sandro Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome. This event is the latest in a series of conversations we host throughout the year. At these events, we come together as a community to engage with issues core to health. What we do about health starts with how we think and talk about it. When we gather to engage with the ideas that shape health, we contribute to a conversation that informs how we address health at the local, national, and global level. Thank you for joining us in today's conversation, and a word of thanks to many who made today happen. Thank you to our co-host, the Robert Wood Johnson Foundation, and thank you to Meredith Brown and Alicia Noel for coordinating this event. Health is much more than doctors and medicines. It is the food we eat and the water we drink. It's our education level. It is the quality of our homes and neighborhoods. It is the money in our bank accounts or the lack of it. It is the people with whom we interact. It is what we call social determinants, the high-level forces that shape the context of our lives. The influence of these forces is like the air around us, so ubiquitous that we often forget about it. Yet, they are the lens through which we should view health. In the past months, 2 reports have been published that elevate our focus on the social determinants of health. The Rockefeller-Boston University 3D Commission and the Robert Wood Johnson Foundation both publish reports on how we can use data to better engage with the social determinants of health. We are joined today by a panel of global experts and commissioners on the commissions that produce these reports to guide further discussion of how we can best pursue this engagement in the 21st century. Thank you to all our speakers, and thank you to everybody for being part of this conversation. Here to moderate the conversation is Ritu Chatterjee. She's a science and health correspondent with NPR. Her work has appeared on popular NPR blogs like The Salt, Goats and Soda, and Shots, and on the radio on shows like NPR's Morning Edition and All Things Considered. Her work has also appeared on the BBC World Service's website and radio show Boston Calling. It has been nominated twice for the South Asian Journalism Association Journalism Award and has been recognized by Gabriel Awards. It's really my great pleasure and privilege to turn it over to Ritu. Ritu, over to you.
Thank you, Sandro, for that introduction and for the invitation to moderate this panel. I'm very happy to be here with this, our distinguished panelists. And, you know, as a health journalist, my colleagues and I have spent much of the past 20 months, and actually even before that, sort of covering how the pandemic has exposed and exacerbated the so-called social determinants of health. And we've seen over and over again how, you know, the pandemic has affected marginalized communities, especially communities of color. So looking forward very much to hearing from our panelists on how we can address these factors that are the root causes of these very disproportionate health outcomes. So I'll go ahead and introduce our panelists. We have with us Dr. Gail Christopher. She's an award-winning social change agent with expertise in the social determinants of health and well-being and related public policies. She currently chairs the board of the Trust for America's Health and has been the executive director of the National Collaboration for Health Equity since 2019. We have Dr. Eric Goosby, an internationally recognized expert on infectious diseases with a specialty in HIV/AIDS, clinical care research and policy. He's currently a professor of medicine at the UCSF School of Medicine, a member of the Biden COVID-19 Advisory Board, and he serves on the San Francisco Department of Public Health Policy Group for the COVID-19 response. Dr. Laura Magana, the president and chief executive officer of the Association of Schools and Programs of Public Health. During her tenure, ASBPH has significantly grown its global engagement, launched the Academic Public Health Leadership Institute, and enhanced the voice of academic public health through advocacy efforts. And Dr. Alonzo Plow, who is the Robert Wood Johnson Foundation's Chief Science Officer and Vice President of Research, Evaluation, Learning. He's responsible for aligning all of the Foundation's work with the best evidence from research and practice and incorporating program evaluations into organizational learning. So I want to start with Dr. Gail Christopher. Dr. Christopher, what are sort of the key takeaways from these 2 new reports on the topic that Sandro just mentioned, the Rockefeller-BU 3D Commission and the Robert Wood Johnson Foundation reports?
Thank you so much, Ritu, for the question and for the gracious introduction. I'm very excited to be able to respond to that question and to put the response in the context of the theme of this panel. It says moving the needle, it says take action. And I think what's so important about these two reports is that they are designed to stimulate action on the part of not just the public health sector, but the broader sectors that influence the quality of our lives. And I want to focus a little bit on the synergies that are there between the two reports. One, I think, is that they're both holistic in nature. They recognize that we really have to step back from our narrow focus on what happens in the doctor's office or our narrow focus on sort of rear view perceptions of data, and really transform the way we think about data as a reflection of the quality of life that we as countries, as regions, as states, as localities can create, for the people that live in those communities. So they both call for a holistic view and a broad holistic view. The Transforming Public Health Data Commission used an action-oriented racial healing framework so that we could drive a really let's get it done kind of attitude, in terms of really identifying the things that we must change. And so the three buckets for the Transforming Public Health Data report, they focus on the fact that we have to shift the stories that we tell. Now we know that the public health field really took some hits during COVID, but in truth, the field of public health was in trouble before COVID in terms of the public perception of what public health is, what public health does, and how much it must be a priority for investment. Less than 3%, I believe, of our investments in healthcare go into public health. So our first group of recommendations, they really center around putting equity and the demand for equity, the priority of equity, into the new story that we're going to tell about public health. And I think that that's also a theme of the 3D Commission from a more global perspective. The Transforming Public Health Data project really kind of focused on the urgency for this country. But as this week is reminding us, as we listen to the outcomes of the climate summit, we always have to see ourselves interconnected and interrelated in a global context. The other major recommendation, and it holds true for both reports, I believe, is this focus on ownership, governance, and community engagement, so that the people who are most affected by data actually have a voice in determining not just what that data is, but how it's used, and how does it respect the communities, and how does it really drive change in those communities. So that's the second major area of our report, Transforming Public Health Data, and it is a common theme in the 3D Commission. And then
Can I interrupt you here quickly? Could you just elaborate on when you talk about data, sort of just for a layperson like me who's covering health, but not on the research or policy front, like what kinds of information are you talking about here?
Well, typically we're talking about measuring, historically, we've been measuring rates of morbidity and mortality. How many people died from COVID, how many were exposed, how many incidents of disease do we have? We're suggesting in this new dispensation that these commission reports are driving for, we want to really measure the things that shape our lives, access to quality education, access to an engagement in a livable wage paying employment. When you get into the social determinants, you really want to be measuring, how well are we doing? Access to affordable housing. We didn't talk about the fact that we have a crisis in this country in terms of the lack of access to affordable housing. But if we do this work correctly, we will begin to measure and document that in real time at local levels, things like that. And I'm so glad you asked that question. But in the final area that we focused in on, you can't really talk about the issues of housing and education and exposure to toxics environments, you can't really talk about those in a contemporary sense without taking a historic look as well, in terms of how the patterns of structural racism have led to the conditions that we're living in now. So we think that both of these reports will help us to open up a new way of framing the opportunity and the challenge to tell a new story, but also to drive actions that have to occur.
Thank you very much for that. So I want to turn to Dr. Gooseby next. So tell us how understanding the social determinants of health can actually have an impact on people's health. Like, how can it shape policy, and how can we ensure that that policy change happens?
Well, thank you, Dr. Chatterjee. That's a very pointed question. I want to thank you for the kind introduction as well to this important topic. I think that Dr. Christopher's discussion about the complexity of understanding how our disease manifestations, how disease moves through a population, who it impacts in that population, who it doesn't impact in that population, give policymakers the information they need to prioritize and target interventions to maximize those outcomes. If we don't have the data, we don't know who it benefited, and often more importantly, we don't know who did not benefit from it. The social determinants created the context in which disease processes that are genetically and environmentally driven, which is a more traditional understanding of disease and a population in a community. It began to be clear that our understanding of how the disease moves through that community, who gets it, who suffers from it, is not fully explained by the genetics and the pathophysiology of a disease. We realize that how an individual is situated in society, how resources come to them or don't, their perception of those resources and need for those resources for their own health, the health and well-being of their family and their community. Those dots are difficult to connect, but are the completion of our understanding for how a disease might impact the population. HIV is an example that occurred in slow motion compared to COVID, but the exact same things challenged the population. The virus moved through the population in the same way. And I would say, reminded us of the interplay of social situations relative to other individuals and groups in the population become critical for policymakers to understand where to put their resources. That ability to understand the data, to understand how it impacts one individual versus another individual, to begin to move into causal relationships with those situations or disease processes, allow an accountability to move into both the governance of how you move capability into a community, the ability to put people in a room in the right discussion about the right topic for the right decision to be made. Data informs that, populates that, and better ensures it. And I think it's the core of the accountability. Yeah,
sorry to interrupt. Could you give me an example?
Our ability to understand in the initial outbreaks of COVID who was initially impacted, the predominance in healthcare workers, people in congregate settings, our prisons, nursing homes, the early recognition of that allowed public health measures to be taken to minimize that threat as our understanding grew and as our interventions were deployed. So where to put the PPE, how to move with isolation, distancing, et cetera. There's a rationale that's better than just everywhere in a deployment decision. And those types of critical decisions come out of an understanding of the data.
Thank you very much. I want to go to Dr. Magana next. I'm wondering, what were your key takeaways from the report specifically pertaining to training the public health workforce? What needs to happen there?
Thank you, Ritu, and thank you also for inviting me to be part of this important webinar. So from an educational perspective, I would like to focus on 3 key actions needed to advance the recommendations of both of the reports and move the needle on social determinants of health to develop a health system that really works to improve health and well-being to everyone everywhere. Number 1, the urgent need to educate a competent and compassionate public health workforce with a strong focus on health equity, commitment to community engagement, and data for decision-making. So the only way to significantly advance the health and well-being of populations is through the lenses of the social determinants of health, which is why social determinants of health are at the core of the work of schools and programs of public health, focusing their teaching, research, and service on addressing the social problems that cause poor health: poverty, inequality, violence, racism, housing, transportation, environment, and so on. So public health education also needs to focus more on developing competencies around health data management and information systems. This has become more than evident in the last 20 months. Data gaps have already been shown to limit the COVID-19 response. So data availability is a critical factor in tracking the progress of the health of the populations. So we need to emphasize in our curriculums more the connections between data, social determinants, and decision-making to strengthen the health systems. So a systems thinking approach is key in our education. So we must develop a public health workforce that values and prioritizes lifelong learning. Academia needs to adapt and embrace new technologies, models of learning, to provide opportunities that fit the needs of the current and the future workforce and current and future students. This focus on lifelong learning will help ensure that the workforce is able to stay up to date and new knowledge and competencies in a fast-changing environment. Concentrating on the public health workforce is not enough. It's fundamental, but not enough to move the needle. So number 2, in the vision for a new and better future, we need to generate spaces for interprofessional and interdisciplinary education. We already know that addressing the social determinants of health is essential to advance the health and well-being of populations. However, many decisions that affect the social determinants of health are not made within the health sector. A multi-sectorial systems thinking approach is needed to identify the interconnections between health fields and health adjacent fields such as law, farming, city planning, engineering, environmental science, and many others. An interprofessional approach that embraces health equity and social justice will bring together data from many fields that impact health to allow for better evidence-based decision-making in all the fields. So to achieve this type of interprofessional collaboration on a large scale, we should start by transforming the educational structure to provide more interprofessional education. So within health professions and beyond health professions. Well-being and health are the societal values that we all share. And all professions, regardless of their expertise, they need to have foundational public health knowledge and develop the competency to assess how a specific field or discipline contributes to better health. So moving the needle will require that every single professional have foundational knowledge of the conditions that generate health and how the lenses of their specialized profession impact the well-being of populations. All the way from community colleges to undergraduate to graduate to lifelong learning, developing competencies on social determinants, data, and decision-making at a foundational level first, and moving to specialized levels as we move upward into the educational ladder. And if we are serious about reshaping the future, we need actually to start in K-12 education, making sure all citizens are educated not only in Public Health 101, but also in the human competencies, such as empathy, compassion, resilience, that this world desperately needs in order to move the needle. And finally, with these competencies in place in all professions, then we can talk about a whole of government approach to secure health and well-being in all policies. Because the systems thinking approach must reach beyond, or must be, beyond the professions and the disciplines into really reaching the government. A whole of government approach is needed to ensure that the right to health is considered and protected at the highest level. This could serve as a basis for cross-agency collaborations and to establish collective standards, definitions, and priorities. A whole government approach also engages other community, national and global partners. It actively seeks out engagement with experts from different sectors and from all potential impacted communities. This will bring an understanding of the disproportionate health impacts felt by vulnerable populations, as well as the impacts of historical inequities on health and the social determinants of health. So this approach encourages governments to develop transparent systems that collect data about the social determinants of health and explicitly use this data in decision-making processes across sectors. So moving forward on these action steps will not be easy, but they are necessary to set the foundation for achieving the recommendations of both commissions. Schools and programs of public health are committed to moving the needle on social determinants of health within our own field, but also collaborating with the others in order to really reach the interprofessional education that we need, and the government agencies and working with the government also agencies to achieve better health for everyone, everywhere. So I'll stop here. So looking forward for the Q&A.
Thank you very much. Dr. Plow, I want to go to you next. Tell us why the Robert Wood Johnson Foundation fund this commission and how the foundation is addressing some of the needs raised by the pandemic.
Great. Well, again, great to be with you all today and all of the listeners in your various time zones. This report, this charting a course for an equity-centered data system, just goes to the core of what the Robert Wood Johnson Foundation has been doing just really over the last 10 or 15 years, as our focus has moved fairly squarely on health equity, racial justice, which we define as the operational principle of achieving our broader vision of a culture of health. And we've been working in partnership with many others to build this culture of health rooted in equity, fair and just opportunity to thrive. And I think when we talk about the social determinants, we use that term thrive to say this is more than understanding disease prevalence. The goals we have in health equity and building a culture of health are that communities thrive, well-being, positive health. And I think both of the reports speak to the power and the necessity of using these social determinants to get behind the relatively narrow, though important, but relatively narrow definitions of data that are solely focused on essentially disease prevalence. So we need an agile, modern data system, public health data system to guide decision-making rooted in communities so that they thrive, we thrive, and not merely respond to the next threats that are upon us. So the foundation, and then those who don't know the Robert Wood Johnson Foundation, we're the largest foundation in the country solely focused on health. We've been investing our work in public health data infrastructure for a long time, many years, really to provide community leaders, residents with health data resources around the drivers of the social determinants of health. It's been essential to us. And I like the way that my colleague Gail talks about this, that we have the right information to tell the right stories that affirms a community's role in building equitable places where we can thrive. And over the last few years, we've really doubled down on that as a focus. You know, COVID-19 pointed out long-standing problems in what I'll generally call the health information system, but they certainly didn't start with COVID-19. They preceded it. And what COVID-19 showed us was how really the scale of the challenge, the implications of not having the right kind of hyperlocal data, not having the kind of data that engages communities in problem solving, and data that is not timely information, that is not connected across sectors, so that we can understand, even in a response situation like COVID-19, how to address something like a pandemic. But for someone like me, who's been a local and city and county public health practitioner for most of my life, the real goal are preventive information that helps us to kind of get in front of these kind of threats and are much more affirmative data that affirms how we can build resilience and thriving communities. And I think some of the other speakers have already spoken to that. So all of that was behind why the foundation has always, for many, many years, seen data, let me call it information, as absolutely key to improving health and well-being in the country. And that's where the social determinants work has been so important. And our funding of this first of its kind National Commission to transform public health data is really been part of that. I think that the other thing I think both reports make clear is that this is far beyond just a governmental problem. When we talk about public health systems, we really need to be thinking about beyond just governmental public health, because the social determinants, almost by definition, are really influenced by other things. We talked about that today: schools, businesses, other organizations, and we need information and we need data and information from those sectors as well. In fact, social determinants data generally reside in those places. And we saw during COVID, kind of going back to that, what happens when you don't have appropriate data in schools. And I think it was already mentioned, what happens when you don't have appropriate data in the criminal justice system, in the carceral system, so for early indications of a high COVID prevalence that actually should have been anticipated with that kind of the conditions of the CJ system. But again, not linked in any dynamic way to our general public health surveillance system. So again, the foundation's commitment over many, many years has been kind of driving our awareness around this interdependency of sectors, community-driven information that can make a difference in policy building. Because it sounds hackneyed, but health is a community thing. It derives from location and place. And again, never discounting the role that our formal systems play, but the ultimate generation of health are in the life conditions through the life course in place that we hope are influence thriving and well-being. And I think both reports speak to that. The foundation's work over many years is focused on that. And we funded this effort, and we funded $50 million in follow-up investment to, paralleling the recommendations of the report to really be a catalyst for this change. And final thing I'll say is that I think all of it's important for both reports and all of the listeners. This is an opportune time with the current administration's focus on a whole of government, with taking very seriously learning from COVID, learning from the George Floyd murder, the kinds of data that need to be incorporated in these systems. And I think both reports have taken the discourse way beyond just data modernization to something that is deeper and more deeply reconstructed and oriented toward better than our usual public health data systems. As, again, a longtime practitioner, I know that we're going to come out of this with better infectious disease monitoring. That's actually, as difficult as it is, that's the low-hanging fruit. the more deeper understanding and connecting sectors around social determinants, that's what I think both of the reports are really trying to achieve. And that, again, that was sort of a false ending. The real ending is of this comment for now, false coda in music terms. But you know, if structural racism is a public health problem, you're going to have, which it is, and the CDC director said that in the field is responding. You're going to have data and information systems that address it in a root causal way. And I think both reports speak to that.
Thank you for that. So I will move on to the discussion now. I have a few questions, and then we have some questions coming in from the audience already. So, and feel free to jump in and throw your own questions and respond whenever you want to. I guess this question, my first question is, I have to sort of bring a little bit of my journalistic skepticism. What you all are proposing is so necessary, what the reports are proposing is necessary and important, but also huge changes in some ways, right? You're talking about changing economic systems. You're talking about sort of really revamping, like not just training public health workforce, as Laura mentioned, but you also said, like, we need education to change and incorporate health information everywhere and understanding of social determinants. When it also, we need political will and long-term, and often you don't have this kind of long-term thinking when you're talking about politics. You need economic systems to change. So I guess my question to you all is, do you really see that happening? Even if it's at a very macro level, and if so, where is that already happening, and what's being done already to address social determinants of health? So and what's really going to take sort of a long term sticking to those that approach?
I'm going to dive in because I'm impressed with the outcomes of the last election we just had this week at a micro level. There were ballot initiatives that passed that really do speak to reforming the criminal justice system at the local level. We always tend to hear more about, what's popular in terms of political division, but there were some amazing things actually happening on this country on the ground, where the people said they want more money to go into social services. They want more money to go into strengthening the safety net within their local communities. So I think, this was an unprecedented moment in our nation's history, not just the turning on a dime in terms of the response to COVID, but we also had the largest protests for justice in the history of this country, upwards of 20 million people. That led to an outpouring of resources from all sectors to try to make the change. Now, it's no longer in the headlines, but things are happening, and it has catapulted us into a new way of thinking and a new way of acting. And every time, there's real change, there's real resistance to that change. So the polarization is sort of to be expected at a time of great change. But I, for one, am very optimistic, and we have more women in positions of leadership in this country than we've ever had before. We have more people of color at the local level, and my goodness, the amount of money that was finally allocated, not only for the recovery of families in terms of COVID-19 at the federal level, but also this recent infrastructure bill that was a semblance of bipartisanship and it's having been passed, so even though the headlines may make us think that these are the most dire, divided times we've ever had, there are things happening on the local level. Our challenge is to make sure we are documenting, we are measuring, because what gets measured gets done. And that takes us back to the importance of these two commission reports at this point in time. But we really have to monitor and follow up and invest and make sure there is a sea change in what's being measured and documented, and more importantly, communicated to shape the narrative for the future we want.
You know, I was just looking up for a talk I was giving this past week. I just looked up some estimates by nonprofits that work on childhood poverty, and apparently, you know, COVID relief packages have, and other efforts have reduced child poverty by half. So that's like, that does address social determinants of health. Anybody else want to take?
Yeah, you know, I would like to, you make me smile with your optimism, and it warms my heart that you are so articulately conveyed this moment, because it is everything you said, and it is important we don't forget that. I guess I fear, though, in all of that, and this is a very different mobilization, especially in developed world settings, that we've ever seen before. But what it also showed me was the inability to clearly identify a government, in the private or public sector that is accountable and answerable for standing up and implementing in a setting where data was not available for months. And the inertia that was created in the 6 counties that touch the Bay Area, the dialogue between private sector third-party payers and public departments of health as to who's responsible for this took weeks with the best of intentions. The lack of clarity around who should take the lead in defining unmet need, prioritizing the unmet need, and making the allocation decisions toward them. How do issues of inequity factor into that at the beginning of the conversation, not after the fact or after we see the outcomes that didn't occur equitably across the population, but at the beginning of the population? The only way that is informed is through data that's collected. And so I want to really underline your point that the challenge is to look at issues of disparity, inequity of access, and follow it through to see how that reflects in the same outcome or a different outcome for that population, keeping track of that. After all that being said, after that's clearly a charge to kind of academe to do this, to understand and mobilize this, to articulate it and explain it. Foundations have a role, private sector has a role, different. But the conversation about what are the priorities that come out of that conversation, there will be differences across the population. And we haven't agreed on a process that allows those differences to be in a safe space presented and worked through, and still insist that a decision be made that reflects the inequities in the system. So I again say that comes back to the data collection that tells us it is or it isn't on target. But governance, accountability are huge, and I think the COVID frenzy showed us that very clearly once again.
How can we make sure there is accountability, in your opinion?
I think that the data collection is where the conversation starts, but it is a political system that moves a politician. And I'm gonna say it really clearly. Academics, primary providers of care need to see their political role in conveying this need and this lack of equitable distribution of access to services and the outcomes they create. That has to come out of our mouths because we're in front of it in caring for our patients and our populations. And we don't seem to think it is our job to convey that inequity, disparity we look at every day in that kind of work to political leadership. They will go with their ears closed and their eyes closed unless it is shown to them and they are forced to answer to it. And even then, they will find ways not to. I don't have a good solution to it. I don't have an example of where it works well. I think the movement to private sector foundation solutions for problems that are central government responsibilities has emasculated government's need to be accountable. We've got now foundations and corporate entities standing up and saying, we're going to be responsible for what was a clear government responsibility before.
Well, if I could.
Yeah, I just want to finish with this, Gail. The re-equilibration of that imbalance, the discussion that would allow that to re-equilibrate hasn't happened yet. And I hold in a big part, academia responsible for that. If that is not the role of that forum, then what is? But it is not being discussed at the level it should be. And we are failing to engage. Let me be quiet.
Well, I just wanted to, you mentioned the word leadership, and too often that is missing from data conversations, and I couldn't agree with you more. Public sector leadership has to be held accountable. But given what we have right now in terms of public sector leadership, that also demands education. And so one of the things, education of the public sector leaders, so that they understand the broader complexity and context, and they don't feel that there's nothing they can do. And so both of these reports call for a more interconnected, integrated, cross-sector approach. And I think one of the immediate needs is for educating public sector leaders so that they get what these two reports are promoting, what they're saying, so that they realize that they could actually track and measure and hold themselves accountable for achieving very specific quantitative and qualitative outcomes. So I would say one of the next steps of this important work is to bring it into the periphery, if you will, the center, the perspective of public sector leaders at all levels, so that they get the fact that this is not just in a silo somewhere in the public health department. This is everybody's role. Governors, mayors, city council representatives, everybody has to be at this table. So I appreciate what you're saying, but I really think we have to focus in on how to educate and how to partner.
We could do another hour just on this one. But I'm a very short-term philanthropist, but I'm gonna come back here to philanthropy. I'm a long-term former academic and former public official. And, data alone never made any change. Data to action to a political nexus can make a change. I think, the book our colleague at Morehouse, Daniel Dawes, wrote on political epidemiology speaks, I think, to what the challenge ahead. It is really understanding social determinants in that action framework through politics. And I think it is the reason I'll put it this way. I'll put my philanthropic hat on. The reason we changed all of our research programs to something for action, data for action, policies for action, evidence for action, and I can say this as a longtime academic, that data to action doesn't drive the core tenets of the way we do research in most of our fields. And I think that is part of the problem. And Laura and the foundation are working on a project, which I'm not going to steal the thunder of that announcement, to try to think about together how we can support some of the efforts in schools of public health, to think about academic excellence, scholarly excellence in a very different way around action and around community engagement. I guess the only other thing I would say, Eric, and this would be the other hour conversation, and maybe when we're both in California at the same place, what has diminished the role of government in the minds of people so that it isn't as robust and trusted sufficiently to play the role that only government can play. I wouldn't pin it on academics. I sort of wouldn't pin it on foundations, but I would say something happened over the last 50 years or so that has made government suspect, and we saw that in COVID as well, around the lack in trusting of information because of this diminished national set of the role of government. That's part of the mix, but I guess I'll stop there. I know Laura has something she wants to say.
Yeah, thank you. Just to add, I completely agree with all of you in your comments in terms of what we need to do now in order to do something with the current situation. But I really want to go back to emphasize the importance of education. I'm a true believer that it's through education that we're going to change for a sustainable world. So if we think about, yes, there are some things that immediately we need to do with the current situation, with the current workforce, but I think it's extremely important we look back to the new generations and what are we doing right now in the curriculum for K-12, high school, and of course, all our careers in order to prevent or in order to create better human beings, better citizens that in the future, we all gonna be thinking about collaboration. We all gonna be thinking about the importance of subtle and all these topics just because it was in our education curriculum all these years along. So there is optimistic about that because I believe in the future generations. And I know that if we do our work right now, the future generations are gonna be able to do it. Of course, we need to keep on doing what we're doing right now to the current one, but we really need not forget, we don't have to forget that there's a lot of chance for society to work in education right now in order to change the future generations.
Actually, thank you for that, Laura. And I'm going to pick, we have a bunch of questions and there's one specifically for you. It says, how specifically is competency in social determinants actualized in training in schools of public health? Should it be spread to other college, high school, and even middle school curricula, which is, I think you would agree with that it should. Is ASPPH doing this, especially for middle and high schools?
So the first question is yes. I mean, most of our curriculum, if we just talk within ourselves in public health, of course, we have several competencies that deal with understanding the conditions that, surround the humans in order to what are the things that are really impacting our health or our sickness, right? So I think that the current public health professionals understand and have opportunities during their curriculum to understand very well this concept and really act on this. The problem is that we need to, and we are doing something, yes, ASPPH really works collaboratively with others, especially the other health professionals in order to have all the same content in their own curricula as well. Now, let me tell you that COVID has helped because before COVID, even the health professionals would not pay a lot of attention to prevention or the conditions. They don't have this content in their own curriculums. It's hard to believe, but that's how it is. But right now, they really understand the importance of doing that. So I'm hoping that for the future, we will do more collaboratively and working together as teams of health professionals in order to address all these topics. And as I said, beyond the health professional, we need to start with our own house, but we also need to be working with the others in understanding this. And there are conversations right now in order to go and move beyond to the high schools and that. So yes, we are at ASPPH. These are part of our conversation and our vision for 2030. Yes.
Thank you. So the next question, another question we have is, given the stinging criticism from some regarding diversity initiatives at institutions, as well as attempts to purge any mention of race, for example, so-called critical race theory from learning institutions, could the panel address how best to move forward on social determinants of health in the context of these political headwinds? Gail, do you want to?
Yeah, please.
Yeah, Eric, go ahead. No, Eric, go ahead.
Okay, well,
Okay, I was just going to say the core for all of us have already clearly played our card to commit to the importance of data collection, the intellectual honesty that needs to be intimate with that in the data collection process and analysis as you aggregate it. And there's many areas that as that data moves from site to analysis to change policy to change a budget to invest or not invest in a program, you have many opportunities for it to get corrupted. It's important that we all understand where those vulnerable areas are and are all focused on keeping the integrity of that system together as it moves toward the reflection of what's happening to that population. And I think the local public health interests are closest to seeing and understanding that. And I believe for the most part, your local data input comes in high quality, but usually gets diluted as it moves kind of up that food chain. That remains the backbone of decision-making and policy, strong, correct policy decision-making when it continues to feed into the outcome that it creates. So it doesn't stop with the initial funding decision, but the outcomes it creates go back to policy decision makers. So in year 2 funding, not in year 5 or year 10, adjustments can be made to better target around issues of equity. And I'm speaking specifically to that. So data collection is the core.
I agree with you, of course, having directed this, but I want to remind people that data absent the human development that Laura spoke about, the data about disparities and inequities can often drive further polarization if we don't at the same time simultaneously develop the capacity to really care about diverse populations. And some of that is in being strategic about showing the self-interest that is to be served by having a population that is healthy, that we don't have to allow our healthcare costs to bankrupt us as a nation. So, there's some subtleties and some very important ways that we have to make sure the data is politically grounded so as to, and I appreciate, Alonzo, you mentioning Daniel Dawes' book. He does a wonderful job of reminding us that it is economic self-interest and political mobilization, and of course, access to voting. All of these are critical factors in determining that we can actually drive an agenda that is going to bring about an outcome. But we have to do some work in this country of learning how to genuinely care for the well-being and the interconnectedness of all of us as a human family. We're still living and swimming in an ocean that devalues human beings based on their physical characteristics, that marginalizes and otherizes. And so we have some real core work to do to change and build the capacity to where the data will even matter. Because you and I saw, the more we learned about the disproportionate impact of COVID on communities of color, the louder the voices became that COVID wasn't real. So we really can't be naive as to the challenges we face in terms of shifting our understanding and our capacity as human beings to value one another. I think that's really important in this moment.
I have a somewhat related question about sort of the value, how data is collected and what meaning it can have. So this attendee says, a speaker at APHA in Denver talked about the gap in our understanding of and data for the social determinants of health because of underrepresentation of Hispanics in research. He pointed out the usefulness of using community-based participatory research, understanding that community residents or leaders are key to recruitment. He also pointed out the failure to realize that when we translate surveys into Spanish, that there are numerous countries represented in the Spanish-speaking population. So there is not just a single appropriate translation. So my question is, how without representative data can we measure the social determinants of health?
That goes to the core of, I think, some of the recommendations in, I think, both reports under the two scientific signing data disaggregation umbrella. What you're really, we are not dealing with the multiple nuances of people who have been marginalized unfairly because of race, language, this differing tendency in America to marginalize folks, and our data systems have not been sufficiently attuned to understanding those differences within racial groups, within ethnic groups. And many of the recommendations of our report are around changing the way we get information about that in a much more nuanced way. I want to emphasize that what we've been talking about, I think, in both of these reports is information. Data conventionally defined is a piece of it. I know one of the questions talked about the role of narrative and voice in qualitative data. Yeah, the data systems of the future, the information systems of the future have case studies and narrative and community voice. And sometimes that is absolutely actionable. I can say that is as a local public health practitioner, sometimes that can be very actionable when that voice is effective and supported. So I think part of this is under the thing of meaningful community-derived, community-linked data, information that leads to action, data that leads to change. And data that can assist policymakers to confront the empirical reality that marginalization, racism has a negative impact on health. That goes to your previous question. The way to deal with the forces that don't want those empirical facts to be known or to bring the evidence forward that those are facts and not just ideology. And then, and then just continue that work. But as again, my colleague Gail said, this is long work and is going to take some time.
Thank you. And I think this also goes to another question that says, I think you somewhat answered this other question, which says something we've come up against in the health space is the heavy reliance on data to inform current policymaking while also grappling with the reality that some communities are not accurately reflected in health data, particularly low-income and racialized communities. How do you balance the contemporary data push with the need to include other knowledge-based exercises like anecdotal evidence? And I think, Alonzo, you just addressed that.
And the census undercount, right? I mean, the same fact, again, the influence of sort of the structural problems and political problems in data are best evidenced by the census undercount, right?
Yeah. Another question we have is, how do we address the lack of trust between communities of color and the healthcare industry? If one of you can just do that quickly, if there is a quick answer, because we're almost out of time.
Very quickly, we really do have to diversify the healthcare workforce at all levels. We don't have enough people, diverse people of color, interfacing and making decisions. And that's a step in the right direction toward trust. But we also have to be willing to be creative in terms of creating new ways quickly to do that, because we're not going to do it quickly enough under our current model. So we really have to think of new roles that can be integrated into the healthcare delivery system to help bridge those gaps and divides, I think.
Thank you all so much for this discussion. I can keep talking to you. This is just so fascinating and important, but we're almost at time. So thank you all very much. And I'm going to hand it back to Sandro Galea.
Well, first of all, let me echo the thanks. And Ritu, thank you for masterful moderation. That conversation really felt like it was just picking up, and it could have gone on for several more hours. And there was so much that each of you said that I could pick on. But if I may just take one thread, just to draw it sort of to a close, is this notion of data as information and data as telling stories, and the plurality of different types of data and how we can understand them. And I think what both reports aim to do is illustrate some of the challenges around it, some of the opportunities around that. And I for one, think it's an exciting time. I mean, I think these kind of conversations almost sort of sometimes we focus on the challenges, but I think it's an exciting time for bringing data to better understand social determinants. And as we're talking, I was emailing with some of our colleagues who are actually listening in with ideas, and I could just see us all develop ideas even as we're here in this conversation, which I think is exactly what this conversation aims to do and what these reports aim to do. So thank you. I want to say thank you to the Robert Wood Johnson Foundation for one side of the report, Rockefeller Foundation, Boston University for the other side of the report, and to the commissioners on both reports, and really to everybody who's part of this conversation, because I feel like what these reports aim to do is really to generate this kind of conversation that can then be carried forward into better ideas. So